Hi class, in this recording we will be focusing on our DCT, distal convoluted tubule, and the collecting duct. So at this point in our journey, our urinary journey, we've gone through the renal corpuscle, we've gone through the proximal convoluted tubule, the loop of Henle, nephron loop, and now we're at the distal convoluted tubule. So now this filtrate's getting pretty dang concentrated compared to how it used to be, but it still has about 20% of its overall water content compared to the original filtrate, and it still has a lot of the original salts as well. So if we still were to urinate this liquid, we'd still be urinating about 36 liters, or the better part of about 9 gallons a day. So we still have a lot of work to do before we can turn this filtrate into something acceptable for the toilet. So we're going to work with some hormones in this unit or this section. We're going to focus on aldosterone, ANP, ADH, and parathyroid hormone. These hormones that can help regulate water balance. I know we've already talked about them to varying degrees already in this chapter, but review is good. So as we look at the cells of our distal convoluted tubule and collecting duct, we have two kinds of cells. We have the principal cells, and we also have the intercalated cells. The principal cells are diagrammed up here on the top for us. These principal cells are very common. They are the most common cell of the collecting duct, and they help make up the majority of the simple cuboidal epithelium. And these principal cells have a lot of hormone receptors on their surface on the side of the cell facing the blood. And they're going to be used for maintaining salt and water balances. So for instance, here is a principal cell. And when that principal cell is exposed to aldosterone, that principal cell is going to have ATP synthase be upregulated, and that's going to cause more sodium to be dumped into the bloodstream. As more sodium is dumped into the bloodstream, that's going to lower the sodium concentration within the cell, causing more sodium to be sucked up from the filtrate. And as we suck up more sodium from the filtrate, more water will follow that sodium. And as we look at antidiuretic hormone ADH, the effect that ADH has on the principal cell is that ADH causes the principal cell to develop aquaporins, or an increased concentration of aquaporins. So in response to ADH, water will be absorbed directly. In response to in response to aldosterone, sodium is absorbed directly by those principal cells. As we look at the intercalated cells, these are some cells within the renal tubules that are going to be involved with acid-base balance, or acid-base regulation. So these are cells that can either remove, these are cells that are going to add hydrogen ions to the filtrate. And to help maintain overall homeostasis, or like overall membrane equilibrium for the electrochemical gradient, they will also take in some potassium ions as well. Now, as these intercalated cells are releasing the hydrogen ions into the filtrate, the negative anion that is going to compensate for the loss of the positive will be dumped into the blood. So these cells will add hydrogen to the filtrate and bicarbonate to the blood in an attempt to help regulate acid-base balance. As we look at aldosterone, I said it before, I'll say it again, it causes us to retain sodium, salt, or sodium ions more precisely. And aldosterone is a steroid-based hormone that's created within the adrenal cortex. The things that can trigger aldosterone secretion include angiotensin II. We've already talked about this one in detail. So if we have low blood pressure, we have renin that's released. Renin takes angiotensinogen, turns it into angiotensinogen 1. Angiotensinogen 1 is converted into angiotensin 2 by ACE, and then angiotensin 2 will go to the adrenal glands and cause the adrenal cortex to secrete aldosterone. So we've already covered that in a lot of detail in different recording. But other things that are going to cause the adrenal glands, the adrenal cortex to release aldosterone include an elevated potassium concentration or a low sodium concentration. As we look at aldosterone, it's going to act on the thick segment of the nephron loop. So that ascending portion of the nephron loop, the distal convoluted tubule, and the cortical portion of the collecting duct. So the port of the collecting duct that's right at the beginning, not close to the apex of the renal pyramid. And it's going to directly stimulate the absorption of sodium and the secretion of potassium. So not only does aldosterone cause us to absorb more sodium, it causes us to urinate out more potassium. And then water molecules and chloride ions preferentially are going to follow the sodium ion. So the net effect is that we retain sodium chloride, table salt, and we end up retaining water. And this is going to cause both blood volume and blood pressure to increase, and for urinary output to be reduced or decreased. And this reduced urinary output is also going to have an elevated potassium concentration from the preferential dumping of potassium into the urine by aldosterone. Now as we look at ADH, antidiuretic hormone, also known as vasopressin, this is going to be secreted by the posterior pituitary gland. So remember, when we talk about the endocrine system, the hypothalamus produces ADH, and then the ADH is stored in the posterior pituitary until it's needed and it'll be released from the posterior pituitary. And things that trigger ADH release from the posterior pituitary include dehydration, overall loss of blood volume, if we have rising blood osmolarity, so we have too many dissolved electrolytes within our blood, and that will cause us to release ADH, or if we have if we have a decreased blood pressure being picked up by the arterial blood receptors. Baroreceptors, not blood receptors. I promise I can read. So as we look at ADH, those things will trigger the posterior pituitary, these to be releasing ADH. ADH is then going to travel to the collecting duct within the nephron, causing the cells of the collecting duct to express more aquaporins and have increased permeability to water. And then water that's within the tubular fluid will preferentially re-enter the tissue fluid by moving with its concentration gradient, as opposed to losing that water within our urine. As we look at natriuretic peptides, sometimes these are referred to as atrial natriuretic peptides because they're released from the atrial myocardium. And they are going to be released in response to high blood pressure. And the atria are sensitive to high blood pressure because they are part of the pumping mechanisms of our circulatory system. In response to natriuretic peptides, or these ANP secretions, we are going to have more water in our urine and more salt in our urine, causing overall blood volume to go down and blood pressure to go down. How does this happen? First, the afferent arteriole is going to dilate, and this is going to cause more blood to go into the glomerulus, the capillary bed of the renal corpuscle. And as more blood goes in, that's going to increase the glomerular filtration rate. At the same time, ANP is going to constrict the efferent arteriole so that less blood can leave the glomerular capillary bed of the renal corpuscle. And again, this is also going to cause glomerular filtration rates to increase. ANP is also going to inhibit the secretion of renin and also inhibit the secretion of aldosterone. Renin is a molecule that upregulates aldosterone secretion, and aldosterone is a molecule that causes us to absorb more sodium and indirectly absorb more water. So the less renin and the less aldosterone, the more urine we produce. And the more urine we produce, the lower our blood pressure becomes. Natriuretic peptides also inhibit the secretion of antidiuretic hormone. And again, the less ADH we have in the bloodstream, just like with the less aldosterone, the less ADH we have, the more we will urinate. And the more we urinate, the lower our blood volume and blood pressure goes. Also, natriuretic peptides are going to directly inhibit the reabsorption of sodium chloride by the collecting duct, which is going to cause there to be more salt present in the filtrate, and if there's more salt in the filtrate, we will then have more water remaining in the filtrate, upregulating urinary output and downregulating overall blood volume and blood pressure. We also have parathyroid hormone. Now, as we look at parathyroid hormone, It is abbreviated as PTH. It comes from the parathyroid glands in response to calcium deficiency. That's review from AMP1 when we covered the endocrine system. And as we look at the parathyroid hormone, it's also going to increase the amount of phosphate excretion in our bodies. So in addition to upregulating blood calcium concentrations, it also is going to downregulate blood phosphate secretion or blood phosphate levels because we're going to be urinating out more phosphates. And that's something we'll need to do because we get the calcium we need from our bones. So as we are going to work on our bones, to dissolve our bones, to get more calcium in our blood, we also are going to release more phosphate into our bloodstream. And we need to get that phosphate out somehow. The parathyroid hormone is going to act on the thick segment of the ascending limb of our loop of Henle or nephron loop, and also on the distal convoluted tubule, so that we also reabsorb more calcium from the urine. So we find that we have more upregulated phosphate in the urine, downregulated calcium, and because that phosphate is not retained, these calcium ions are going to remain in circulation longer as opposed to rebinding with the phosphate and being deposited in bone tissue as a form of calcium phosphate. Parathyroid hormone is also going to stimulate the synthesis of calcitrol, known as vitamin D3, within the proximal convoluted tubule, and this is going to allow for us to absorb more calcium in our digestive tract, also upregulating calcium concentrations in our blood. As we look at our collecting duct, abbreviated CD, our collecting duct is going to receive filtrate from multiple distal convoluted tubules. Excuse me. Our collecting duct starts within the renal cortex, up here in the cortex, and works its way down into the renal medulla. And as we go from up in the cortex to down in the medulla, the saline concentration, the osmolarity, and more precisely the osmolarity of that extracellular cavity increases. So it becomes saltier and saltier and saltier and saltier. And as the filtrate travels through this tube that's exposed to increasing salinity gradients or increasing salt concentrations, we're going to continually pull more and more water out via osmosis. So as the collecting duct runs through the medulla, it makes the urine 4 times more concentrated at the end compared to the beginning. So we go with the urine having an osmolarity of approximately 300 milliosmolars all the way up to the urine having an osmolarity of approximately 1200 milliosmolars. So that's all we have for this recording. If you have any questions or comments, please feel free to post them in the class discussion board or shoot me an email. And as always, happy studies.